Good morning, good afternoon, good evening. Welcome to the Unboxing AI webinar series, episode number 66. As we wait for our guest today to turn on their camera. Uh, Thank you so much for joining. If you don't know what this is, well, this is every Thursday, 11 a.m. Eastern time, for now 66 times in a row. You will see either me or one of my colleagues talking to one of couples, friends, customers, partners, collaborators, trying to unbox the proverbial black box of AI from the lens of their perspective. If you don't know what Carpal is, well, we are your friendly neighborhood AI platform, helping you navigate the entire complex ecosystem of AI applications that is out there. Hundreds of companies building beautiful products, uh, bringing all of those into your clinical workflows through a single user interface, a single integration, and a single procurement channel. But shameless self promotion aside, I would like to welcome today Dr. Raj Kedar. Thank you, Dr. Kedar, for joining. It's an absolute pleasure to have you here. Uh, Thank you for joining, Dr. Kedar.
Yeah, thank you, Vidur, for inviting me. It's a great pleasure for me to be here too. And congratulations on your 66th episode. Great work. I think you have built a good platform, good company, and congratulations on all your success. And I think it's
So I think
radiology as a
many people
community.
may not know that Dr. Kedar was actually, I think, Kapil's first user, like first clinical user, many
Mhm,
years ago. For a couple of research projects that we had did. So
mhm.
a lot of the feedback you had given us at that time, so we took, and thank you for those kind words.
Yeah.
Of course, Dr. Kedar, generally needs no introduction. He is the chief of radiology at Tampa General Hospital, I think one of the largest hospitals in the region. He is also a professor of radiology at the University of South Florida, the Morsani School of Medicine. He did his residency. Well, he's from Mumbai originally. We'll talk about that. From Grant Medical College, which was like my rival medical college. Uh, but yeah, he from Mumbai, then did radiology at Yale, and yes, then we share another connection. He was at UPenn, where he did a fellowship in body imaging. Uh, More than 200 presentations and 80 papers kind of sums up the impact that Dr. Kedar has been having. I think that the what is not captured in your bio, Dr. Kedar, and you've been very humble about it, is the the community that you have built in Florida of radiologists, right? I think, and this is from memory, but I think you were president of the Florida Radiology Association, and I think you were kind of the driving force behind it. So I don't know how much you get to sleep, but thank you for uh, coming onto the webinar, and would love to hear, Dr. Kedar, your story, right?
Mhm,
Like, from Bombay to Tampa,
mhm,
how does that happen, and what have you learned along the way? I know this has nothing to do with AI, but
mhm.
would love to just uh,
Yeah,
I've listened to
yeah,
the
sure.
story, but I would love for everybody to listen to it.
Yeah, yeah, sure. So, as you know, I did my all training right from being a medical student to resident at KEM GS Medical College, and I was going to continue there as a the staff. But then I had gone to London at Royal Marsden Hospital, where Dr. Cosgrove was one of the pioneers in radiology.
Royal
Actually,
Marsden is a
first,
couple customer, sir. I don't know if you know.
I didn't know that, but I had gone there during my training for just a couple of months, and for some reason they were very impressed with me. So after I came back, there was a position that opened of a research fellow. So Dr. Cosgrove called me and said, "Hey, we want you to be here and help us doing research and do some clinical work." So I was not planning, but that's what happened. That I then got chance to go to London and worked at Royal Marsden Hospital as a research fellow for 3 years.
Oh,
And
wow.
during that time, I had a lot of prolific, I would say, research papers because this was a place where actually ultrasound transducer was built. This was a place where we were working on treatment with high frequency ultrasound for tumor treatment, which came to US almost after 20 years. This place where we did for initial experiments on ultrasound contrast. Yeah, so actually, one of my papers were one of the first ones in ultrasound contrast, were published in Radiology journal. So when I was in London, I used to come to RSNA for presenting that research. And then I got opportunity from there saying that, hey, why don't you come over here? And actually, my brother used to live there. So he said, hey, I will support you. Why don't you come over here? And that's what happened. I applied for green card. I got, approval within few months as a national interest and extraordinary category due to my research papers. And then I did my residency at Yale, followed by fellowship at UPenn. And since then, I've been on this job. This is my first and probably last job here in Tampa. When I joined our group in Tampa at University of South Florida and Radiology Associates, at that time we were very small. We had one imaging center and one hospital. But
Yeah.
then, being a somehow I was just not satisfied with just doing reading cases. Being a street smart, everyone in India is street smart. They know how to negotiate. They know how to go around, find ways to make it work. So that's what happened. I got involved with outpatient business, and then we developed from one outpatient imaging center to 20 outpatient imaging centers, largest provider in Florida. And now Tampa General is the biggest hospital in Florida. We have 1,400 beds, all subspecialties. University of South Florida's all training programs are there, all subspecialty and super specialties. So it is exciting. I became chief of radiology about 18 years back. It was kind of unusual for an
Wow, you
immigrant,
became
and
chief
huh?
18 years ago.
Yeah, yeah.
Wow.
So it was kind of unusual for a kind of immigrant with an accent to become chief of radiology, but
Also
I
young.
I proved myself, and that's what happened. Then we also started developing fellowship programs. So we developed fellowships in body imaging, MRI, emergency radiology, cardiothoracic, MSK, and I also wanted to give back to people who were like me. So we started developing this 4-year fellowship program so that we can have people from India or somewhere who can do 4-year fellowships and become an attending and become ABR certified. So we have trained probably around 10 people just from India here who are doing well and did very well during their 4-year pathway fellowship. So really proud of that, what we have done here. So
Wow, that is.
thank you for giving me a chance to tell my story,
No, I
Vidur.
think it is I have myself seen a couple of the tower imaging centers and of course seen TGH, but wow, like that is pretty incredible that you were chief that long ago, and I think it is very inspirational. But tell me one thing, Dr. Kedar, like how I know that you keep coming back to India and especially Mumbai, and you're very much in touch with the ecosystem here as well. What is different in practice, from a clinical and maybe also a business perspective? Like, how are like at a high level, how is radiology in the US versus radiology in India different?
Yeah, the main thing is I think it's in India, it's like mostly not corporate or big entity owned imaging centers, except maybe Mahajan Imaging. But most of the places that I've seen are kind of mama's papa's shop. Whereas here, you had to go with a larger scale to compete with other people as well as to get insurance contracts and things like that. So, and each center, you cannot just have, say, ultrasound or a lot of there are, I have seen my friends who have ultrasound clinics and things like that, but it has to be a full-fledged, very efficient system, scheduling system. It can be, somebody calling you and say, hey, can you do this thing? It has to go through proper process. So you have to be very efficient, very competitive, and
But
they have to be full-fledged centers. So if you see our 20 outpatient imaging center, each one has got CT, high-end MR, open MR, or high field open MR, PET scan, X-ray, number of ultrasounds, mammography, and some of them have procedural suites. So each one has to be very full-fledged. You cannot have, just one modality center
but
or
Dr.
two
Kedar,
modalities.
tell me one thing. Like you have seen Touchwood such amazing success. Like you summed it into being street smart, but you know, and I know I'm going off script, but uh, what did you do differently, right? Like if you see today, say a 25-30 year old radiologist from India moving over to the US, like what advice would you give them?
Yeah. So first thing is you have to be good in what you do. You have to have unique
Hmm.
skills. But apart from that, you got to do things which other
So
people
you
don't
can't be
like
a
to do.
bad radiologist to begin with, right? Like,
Yes.
baseline is that you have to be. No, I think
Yeah.
many people, disregard that today, that, you can be average and yet do really well. But what you're saying is that the work has to be
Yeah.
good.
I mean, you have to be a good radiologist. You can be a bad radiologist, but the apart from that, you have to have attitude of can do.
Hmm.
If somebody like the one thing is you got to be ready to work harder because you got to work harder to get yourself promoted. Second is you got to do things which other people don't want to do. Those things might be some of the boring things. So if you do that, then you secure or cement your place in that practice because you are doing which other people can do or don't want to do. Because sometimes you have to do a lot of evening hours and other things. But I think it's fun to do it. If I was doing just reading cases, it won't be fun for me. I want the other intellectual stimulation, other appetite to do new things. Otherwise you become stale and the things become boring and you somehow then start becoming irrelevant because the newer people who come in, I mean, they might have a similar or better skills than you,
Yeah.
but you still have cemented your place and you can, kind of give direction to younger generation as well.
Yeah.
Because many of people don't want to put those extra hours, or many people don't want to do things in hospital which may be boring. You might not know much about it, but hospital needs you in
Yeah.
those areas. So you got to develop those skills. You may not have those skills, but you got to ready to learn and explore, new possibilities.
No, that's incredible. So work hard, do things others don't want to do, and keep learning. I
Yeah.
think we should put that on a wall. So before I proceed, everybody who has joined, like, the drill. Please ask questions. You can use the chat box, the Q&A box. Whatever it is that you'd like to use. But please do ask whatever questions you may have. Uh, Dr. Kedar, switching tracks a little bit. So you are also associated with radiology partners,
Mm,
and Rad Partners, I feel, has been one of the most uh, prolific, at least promoters of AI, and also early adopters of AI. So, as a radiologist, reporting scans using the Rad Partners infrastructure, if I may. Uh,
mm,
and then as a radiologist, not having the same systems in maybe your other practice at TGH. I don't know if you have the same systems or not. Would love to know. But as a radiologist who has AI, and as a radiologist who has maybe lesser AI,
mm.
what is the difference? Do you feel any difference? Is it any value at all, or is it still
Yeah,
evolving?
I think AI is still evolving. First of all, I think Rad partners are doing a lot of things which is going to help in near future. They are developing their own platform called Mosaic, which is going to be good. I'm one of the user group and early adopters, but right now I think they are mostly concentrating on dictation system by which you can become more efficient with just dictating positive findings and then AI taking over to
Mm,
create complete report. But the other features that we are using are mostly AI Doc and RAD AI products. So those are useful, makes you little efficient. But I think there is so much more to AI rather than just interpreting images. For example, we use AI for maybe incidental PE or lung nodule or cervical spine fractures or using best practice guidelines and everything. But I think the if we want AI to be more successful, there are many more things that AI probably, at least that's my vision, that it should be able to do it. And people mostly concentrate on, hey, what feature are you going to give me? Or can it detect pneumothorax? Or can it detect, pneumonia or subtle pulmonary nodule or something like that? But I think it can do much, much more, and that will be beneficial to our patients and not just radiologists, but to patients as well as for referring physicians. So, talking about that, I think you got to start first with doing right exam for right patient at right time. That is so
mm,
much important because in US there is approximately 25 to 30% imaging waste in the sense that people prescribe wrong exam at wrong time. They might duplicate exam. They might not know that there was a previous exam. They might not know patient's previous history. So based on that, if it AI can prescribe more accurate exam, patient might have renal failure or patient might have something else. Or allergy to contrast. If it can detect upfront, then it can automatically prescribe the right exam for patient's right condition based on patient's history and what they are looking for. Then I think is workflow optimization. For example, we get so many cases. We want to know which cases to read first, which are going to be more impactful in patient management, which is urgent. So triaging patients for example, for pulmonary embolism or brain hemorrhage or work list prioritization, report structuring, and scheduling, especially scheduling and optimal utilization of AI becomes very important in outpatients because in outpatients you have a fixed cost of all machinery that is there. You got to pay your light bills, you got to pay your MRI machines, lease or loan amount. So you
yeah.
got to optimize those. And many times, what patients do is, if weather is bad, they will cancel the appointment. Some patients are known for canceling appointments periodically. Actually, we used one of the AI to predict that. How can you optimize the maximum capacity of your machines by based on type of exam, whether there are that's, something like 50 or 60 things that they took in account that hey, if we do this, if you do that, then it will automatically send a message to patient who is scheduled next day or day after and say, hey, do you want to come in? We are going to probably going to have a slot open for you at this time. And
So,
if they will
Dr.
send
Kedar,
it to
sorry,
four or
I'm
five
just
patients.
just going to ask you a question. If
Mhm.
so, a lot of the applications you're talking about, these exist today, right? Like these are
Yeah.
real. They all
But
exist.
people are not,
They are
excited.
not
People
widespread,
don't
yeah. But what
know
if
about it or utilize it as
But
much.
what if Dr. Kedar, what if I come to you as like a 22-year-old, IIT or MIT or some
Mm,
technologist. I come to you and I ask, uh, what should I build? Right?
mm,
What is the one AI application that I should build that
mm,
does not exist today? What would
mm.
you suggest? And you can actually say, I would like a better chair. That is also that is also an option.
Uh, I think, I mean, some of the challenges and limitations of what we do right now is obviously we need large data sets, we need diverse patient population, we need
No, but you
high
forget that.
quality.
You basically that
Yeah,
this kid comes to you and says, Raj uncle, tell me what I should build. So what is the
yeah,
one dream use case you would tell that person
yeah.
that if you can solve this for me, it would be, really
Mhm.
amazing.
I think one thing that I would like to see is the way we look at our images. In
Hmm.
the sense that for years now, since multi-detector CTs, and we are doing thousands of images for each patient, still we read cases same way. We will scroll through 1,000
Hmm.
images in axial plane, 500 images in coronal plane, sagittal plane. If somebody can show me to look at cases in different ways so that I can be more efficient, so that it is maybe something like 3D modeling or something like that, by which if I'm looking through body, for example, if I'm looking at liver, if you can give me transparent maybe view of liver and show liver tumor, showing me portal vein flowing, biliary ducts, and other things, so that I can have a quick look instead of scrolling through 1,000 images and 5,000 images and still miss small things. If I can have a model by which I can look at it in different way.
I think Dr. Kedar, that is so insightful. What you are saying is that 20 years ago, when PAX came, and to today, like the number of images has probably gone up 5x,
Yeah,
but the way you look at those images has not changed at all.
yes, yeah,
Right. And so, is there a new way of actually looking at DICOM images uh, that can make the abnormality maybe appear even more? Uh,
yeah.
that
So
is,
I think that's an issue because people do 3D model building
yeah, yeah,
uh, of all these, but they are not really diagnostic. You cannot look at those because those are so crude
yeah,
and just surface rendering. So you cannot really look at those images to see, but make a diagnosis or look at it quickly.
yeah.
If I have a transparent model, say, of the abdomen, then I
Hmm.
can maybe look at the spleen. If there's something in the spleen, then I can just, on those transparent see-through models, I can see the abnormality quickly. I
I
can
think maybe
see liver, I
virtual
can see
colonoscopy
kidney.
is maybe an example of this, right? Like something like a virtual colonoscopy or
Yeah, but still there you had to go through the whole colon 4 times,
yeah.
go back and forth in
Hmm.
prone position, in supine position. I want something which I can see abnormality right,
Yes.
in a transparent mode. You know,
Interesting.
something. I mean, that's my dream to
Yeah,
look at cases that way.
yeah.
Maybe it might be with 3D goggles or whatever it is, but that would be my dream of looking at cases differently. But the other thing is, I mean, the AI industry is so fragmented, and thanks to your vision and some of the AI platforms that are useful in radiology, just because it brings together multiple algorithms into one integrated system that can support clinical care, can detect abnormalities and quantify images and prioritize and everything you guys do. And it's a smooth integration. So those platforms are also important, like Carpal, who can bring the industry together, all products together, because there's so many products out there. Which one I should use? How I can use? Whether one model is better than the other? How can I compete those models on one platform? That is so important. I think if you see 20 years back, there were probably thousands of PACS systems. But
Yeah.
over the time, what has happened is a lot of bad ones went away, or they integrated with the other people with better features. And ultimately, I think that is what is going to happen with AI, because it is just not sustainable or financially viable. Even if I want to buy, say, AI feature, I mean, it's just not viable for me to give 10 or 20% of the what I get to AI company just to tell me that, hey, there's a pneumonia, or
Yeah.
there's a nodule, or there's a pneumothorax.
Right.
I would, then it won't become financially viable unless it brings the value to what you are doing. It makes you more efficient. If it can save me 20-25% of my time dictating case or dictating abnormality. So that's why those features like maybe going beyond the diagnosis, doing
Mm.
radionomics or prognostic modeling or treatment to response to chemotherapy. Hey, it can, if it can automatically measure the tumor volume over the
Yeah.
time and show me where the chemotherapy was started and whether that chemotherapy agent is working or not, and how did that, what happened to that tumor, so that we know quickly that, hey, that agent is working and you
So
can
can I
treat.
ask you one question? This is
Yeah.
since we are almost at time, and it is fascinating the examples you are giving. Many of them I think are being talked about for the first time, at least that I've been thinking. Uh, and Shruti has asked a question like, do you think AI will redefine the role of an emergency radiologist? But I will take that forward, sir, and ask you a question that what if all the solutions you are talking about, and this is a very controversial question, that's why we save it for the last, but what if all the solutions you are talking about went into the hands of the clinicians,
Hmm.
right? Like a neurologist reporting a brain MR, a pulmonologist reporting a chest CT, orthopedic surgeon reporting a fracture X-ray or a spine MR with AI.
Hmm. Yeah.
You know,
So I think that that's a very good question, and it's probably most misunderstood factor of AI. I think AI with radiologist is the best solution. It's better than just radiologist and just AI. And the referring physicians, they are not trained to do radiology. They are not, they might be good in few things that they are looking for, but they are not going to take that liability. They are not going to read the way we read scans. So there might be something which AI might tell them, hey, there is an nodule 5 millimeter, but do they know the characteristics of that nodule? How to follow that up? How to evaluate that further? So I think we are in much better position to
I
do
think
that
also,
rather
Dr.
than
Kedar,
them
just the
doing.
volume of scans is increasing at such a massive pace. And because of that, the downstream clinical work that has to be done is also increasing. Like number of patients is never going down, right? Number of patients is
Yeah,
always going up. And
yeah,
so I think everybody will have just so much more work to do. And
yeah.
that doing each other's work just goes out of the question.
Yeah, and the other thing is, I think because it is radiology, we can invest in AI that
Yeah.
affects radiology, right? The
Yeah.
referring physician, they are not going to invest in AI to
Yeah.
help them read scans because this will be cost prohibitive because they are not going to get paid to read those scans.
Yeah.
So they are not going to invest in that technology for
Yeah.
them to help them out. We
Correct.
can do that because that's our bread and butter. That's the
I
only
think
thing
I
we
think
can
I think sir,
do.
we can summarize the session by saying invest in technology.
Yeah, you're
No,
absolutely
but
right.
thank you so much, Dr. Kedar. We try to stick to the 30-minute timeline, but thank you. It's a pleasure. It's an honor. I look forward to seeing you next week. Uh,
Yeah, yeah,
but thank you for doing this, and thank you to everybody who joined. And yes, I will be here same time next week with new face.
yeah.
Thank you so
Thank
much.
you very much, Vidur. It was great conversation, and thank you all those who attended this webinar. So, good luck with everything.
Thank
And
you.
if you need any help anytime here, email me
Always.
or find me
100%.
through Vidur.
100%. Done,
Thank
sir.
you.
See you.
Have a
Thank
great
you
day.
so
Bye
much.
bye.
Thank you. Goodbye.